So welcome everyone to the PFCC Partners June workshop. I'm Lindsay Galley, I'm the Director of Education for PFCC Partners, and I'm really excited about our topic this month and very excited that our presenter, Gabrielle Gussin, is joining us today as well. She is going to talk about collaborative approaches to prevent nursing home infections. An extremely important topic that it looks like we have a lot of interest in as well. So thanks again for joining. And we get started, I know a lot of us have been Zooming for quite some time now, and we are still Zooming. I'm sure you are all quite familiar with Zoom and the functions, but if you are new, please, as Gabrielle is presenting today, you can mute yourself. And then if you have any questions or comments that you would like to make throughout the presentation, you can put those in the chat. The chat button, the mute button, your video button can all be found on the Zoom toolbar. So please add any questions that you have. We'll have plenty of time for Q&A to answer your questions at the end of the presentation today. And then during the Q&A at the end, if you would like to come off mute, you can let me know that you would like to come off mute by clicking on participants, and there's a little raise hand button. So you can press that and it lets me know that you would like to come off mute. But we have a smaller group today, so I think we can have some open discussion as well. There we go. And again, we are PFCC Partners. We are a small organization with a large vision to reinvent the healthcare industry so that hospitals, healthcare organizations, and all stakeholders get to continuously partner with empowered patients and families as a resource in the co-design of programs, policies, and quality improvement activities. And those empowered patients and families are typically part of our Patient Family Advisor Network, or PFA network. And if you're a patient family advisor yourself and you're not already in our Patient Family Advisor Network, please consider joining. This is an entirely incredible community of really highly engaged patient family advisors, and we really support the patient family advisors by growing their competencies and partnering to co-design effective healthcare systems, processes, and policies across the country. And we do that through building community and shared learning, skills exchanges where we get to learn from each other's experiences and partnering with healthcare, and then a variety of engagement opportunities as well. And so with that, I will pass the presentation off to Gabrielle. And as she is opening, I'm going to stop sharing. Give me just a moment. Stop share. There we go. So as Gabrielle is pulling up her presentation, I just wanted to introduce her. So Gabrielle is a doctoral student in the Department of Population Health and Disease Prevention at University of California in Irvine. Her research focuses on the epidemiology and prevention of infectious diseases. Specifically, she is interested in improving quality of infection prevention and control programs in nursing homes, which is what she is going to be talking to us about today. So welcome, Gabrielle.
Okay, sorry, it just took me a second to get my unmute button there. Thank you so much for the introduction, and thank you everyone for being here today. I was really excited to be invited to speak for this June webinar. And as Lindsay mentioned, I will be speaking about how we could work together to prevent infections in nursing homes. And I was excited to see we have a lot of participants from all over the country. So I'm here in Southern California right now, but I saw we have people on the East Coast, all over. So thank you so much for being with us on this Friday afternoon. Great. So today I'll start off by giving an overview of why are nursing homes an important place to focus on when it comes to the area of infection prevention. And then I'll go a little bit into what are we doing here in Orange County, California to prevent infections in nursing homes. And ultimately, my goal is how can we all learn from this? So I'll go through a few examples of some projects we've been working on and some lessons we've learned along the way. Alrighty. So I would like to start with some numbers. The Centers for Disease Control estimates that just over 1 million Americans receive care in nursing homes or skilled nursing facilities. And strikingly, 1 to 3 million serious infections occur in this setting each year. So almost, when you look at the numbers, it's almost more than 1 per person each year. So a lot of burden of infection. And of course, people getting cared for in nursing homes are often elderly or have medical complications that make them at high risk for poor outcomes from infections. So these infections could have really serious consequences for this vulnerable patient population. Over the last year, nursing homes have been at the top of our attention, of course, with the COVID pandemic, because it's such a vulnerable care setting. And it's gotten attention from the policy side, from academics, from healthcare workers, about a lot of the disparity that exists in this population. Some of the headlines are nursing home care in crisis, policy implications, shortages of staff. And at one point, too, there was a large proportion of the COVID-19 cases were linked to nursing homes. So it's been an area that's receiving a lot of attention, and I hope it will continue, as we move past this pandemic, to get the attention it really deserves, because there's still a lot of work to be done. So the theme of my talk is really how can we work together to prevent infections in nursing homes? And before I get to specifically in the nursing home, I want to introduce this idea of coordinated approaches for preventing infections in healthcare. So many of you may hear that healthcare-associated infections are a really big risk to patient safety. These are infections that occur when people are receiving care in a hospital or any kind of healthcare facility. And a few years back, the Centers for Disease Control, the CDC, released this report about facilities working together to protect patients. And if we look at this picture, you could see an acute care hospital, nursing home, long-term care facility, a public health department here in the center. And what the CDC was really introducing with this report is that patients are safer when facilities work together for preventing infections. And why is that? When we're talking about infectious diseases, these are contagious pathogens. Germs don't know borders. They spread between people. They spread between places. And we've done a lot of work to study that. There's a lot of transitions of care. So patients are really shared. We could look at it almost as a network. Sharing of patients, sharing of germs, and ultimately causing concern for transmission of infectious diseases. So because of all of this, because healthcare is such an interconnected umbrella, working together to combat infectious diseases is really important. And importantly, with this CDC report, they did some fancy simulation modeling that showed what happens when healthcare facilities work together versus each hospital or each building doing their own independent efforts. And they found that more people develop infections when facilities are working in silos, when they're working independently, and that we get this kind of synergy when healthcare facilities start to work together. So a lot of the projects I'm going to talk about in the rest of my presentation build off of this idea that we're better together, and especially when it comes to infectious diseases. And a few years back, so this is from 2016, this exact report was tweeted by Dr. Rochelle Walensky, who some of you may recognize is now the director of the CDC. And she was highlighting this, saying public health authorities and healthcare facilities can work together to protect patients from antibiotic resistance. So these are kind of the superbugs or bacteria that have developed resistance to antibiotics. It's a really high concern and urgent threat. When it comes to patient safety, these infections are more difficult to treat than infections caused by organisms that are not resistant to certain drugs. So I'm going to talk about some examples of work we've done actually to prevent infections caused by antibiotic resistant organisms. You may have heard of MRSA or resistant staph infection, and there's other organisms of concern. But I'm going to kind of walk us through an example. when it comes to working together to combat these types of diseases. And one more thing to mention before I go on is that a lot of the research in the infection prevention world has really focused on these acute care facilities or hospitals. A lot of the resources and funding has gone towards understanding the prevention of hospital-associated infections. And over the last decade or so, I think there's been more work leading into these different care settings and especially the transitions of care, which have a lot of implications for making sure people stay safe even when they're not being cared for in an acute care hospital. And although there's a number of infection prevention strategies we could talk about, I'm going to just highlight one example, and it's known as decolonization. And it's a long word that basically refers to the idea of reducing the amount of germs on the surface of somebody's skin. So you may, if you've ever gone in for surgery, you may have received some special soap to do preoperative bathing. So decolonization is the use of antiseptic products, something like chlorhexidine soap, and oftentimes accompanied by a nasal ointment. And the goal is to reduce the amount of germs on the surface of the body. It's really common for things like before a device is inserted, they'll clean down the surface of your skin, or before surgery. And the reason decolonization is an attractive prevention strategy is because it's an upstream solution. So it works by preventing the shedding of pathogens or germs from the surface of the body. And when we do that, if shedding of pathogens can lead to all sorts of things, if someone is, if their germs are coming off their body, it could go into the environment. It could then persist on an environmental surface. So for example, let's say a doorknob in a healthcare facility. If that's not cleaned or disinfected properly, could lead to a staff member going and picking it up on their hands. If they fail to do hand hygiene properly, they could then use their hands to transfer it to the next person. And this introduces what I like to call shed and spread of germs. So decolonization works by preventing that very first step of shedding. And it's used during these really high-risk periods of time, as I was mentioning, surgery or before a medical device is being inserted or a procedure is being done. And it protects the person that is receiving the special soap, but also those around them. So it's kind of a broad solution, and it benefits the person themselves. Whereas a lot of our other infection prevention tools really just prevent it from spreading to the next person. For example, you could put somebody in an isolated room. That's not going to do anything to help them get rid of whatever germs they have on their body, but it helps prevent the person next in the room next to them. So decolonization is kind of, it helps both the carrier and also the people that they share an environment with. And there's been an abundance of literature on the benefits of decolonization in different high-risk healthcare settings. For example, this was a paper that came out a few years ago that examined the ability of decolonization to prevent infections in patients in the intensive care unit. And this was led by Dr. Susan Huang, who I work with at UC Irvine. And what this study found is that patients who received this protective bath, so they got the chlorhexidine bath while they were in the ICU, and they also got a special nasal ointment. And it resulted in a 44% reduction in bloodstream infections, which are very serious, potentially life-threatening infections that can occur. So we saw this really sizable reduction. And now across ICUs in the United States, many have adopted just bathing everybody while they're in that high-risk care setting in the intensive care unit, that they'll receive a bath with these special antiseptic soaps to protect the surface of their skin. There's been more work to be done looking at what happens outside of the hospital. So here is another paper by Dr. Huang and group that looked at decolonization for people who are just leaving the hospital. So post-discharge, they were just recently discharged from the hospital. And we know that that's another high-risk time for somebody to develop an infection. So this followed people for 1 year, individuals who were discharged from the hospital and known to carry MRSA. And this trial also resulted in significant reductions in infections. So 30% fewer MRSA infections and 17% fewer infections from any kind of pathogen. And importantly, while this was called Project Clear. And while this study was being conducted, they followed 2,000 people as they were leaving the hospital and that had some history of MRSA. half of them received this decolonization toolkit with some education and instructions, and the other half really just received education about the organism and about basic hygiene. And so we saw this benefit, the fewer amount of infections in the group that received the decolonization protocol. Another important thing we learned during this trial was that patients, when they're discharged from the hospital, people go to different places. Some are discharged home. Many need post-acute care in some other care settings. So for example, in a nursing home. And when the study coordinators were following up on these individuals as they left the hospital, we found that people who were being discharged to the nursing home, it was much harder to find out if they were really getting bathed and really using these products. So it kind of opened our eyes to this disparity of bathing and hygiene that's occurring in nursing homes. And so this led us into work that would really focus on infection prevention in the nursing home setting. And there's a number of studies that we've been working on over the last few years, but I'm going to highlight just one, and it's called the Shield Orange County project. So we received funding from CDC to do a public health collaboration. So this wasn't a research study because decolonization had already been proven in large-scale clinical trials to be beneficial for preventing infections during these high-risk times. So this was really a goal to see what happens if we could get a whole region to implement an infection prevention strategy together. So with funding from CDC and support from public health departments in Orange County and California State, we invited hospitals and nursing homes here in Orange County to partake in this SHIELD collaboration. And ultimately, we got 35 facilities broken down in hospitals and nursing homes to participate. And what they received was what we call enhanced bathing training. So we really wanted to make sure that not just that they were going to be using this different type of soap and nasal product, but really that they're going to be giving a good quality bath. And that when bathing is being done, it's being done with care. And the ultimate goal of this was to reduce multi-drug resistant organisms, which is just another way to say antibiotic resistant germs. So this was here in Orange County, where we have about 70 skilled nursing facilities and just about 30 hospitals. And we actually worked with a team at Johns Hopkins to do a special, what we call network analysis, to find out which hospitals and nursing homes share the most amount of patients together. Going back to that idea of the coordinated approach, that patients are safer when facilities are working together. And because we didn't have funding to provide the products for all of the facilities here in Orange County, we invited the top 50 that seemed to be really highly connected. And of those, 35 agreed to participate in this initiative. And so here's just an example of some of the enhanced bathing training that we gave. So we focused on the parts of the body that are really important to reach with bathing, even in between the fingers and toes, really from head to toe, cleaning all, if people have devices or tubes or lines, it's important to clean those as well. We found that a lot of the nursing staff were nervous or scared to touch devices, and often they wouldn't get cleaned at all. So we did a lot of work to build up confidence to say, actually, a bath is more than just a bath. It's a protective bath, and it could actually prevent someone from a serious infection. So we tried to empower the nurses to really understand the value of what they're doing when they're at somebody's bedside helping them with bathing. So we ran this as just over 2 years, from 2017 until July 2019. And we just are getting ready to submit this as a paper for publication. But what I can tell you is that we found that when we looked at the facilities that were part of our SHIELD initiative, they experienced large reductions in the prevalence of these antibiotic resistant organisms. And in nursing homes specifically, we had significant reductions in the number of people that had to be transferred to the hospital because of an infection. And that led to a lot of cost savings due to those prevented hospitalizations. So much so that we actually got the attention of our local Medicaid, Medicare agency called CalOptima, and we partnered with them after, kind of as SHIELD was ending in the months leading up to our end date. CalOptima came up to us and said, we don't want this to end. We're seeing there's so much benefit here. How can we work together to keep this going? So that's kind of how we started a partnership with our local Medicaid agency. And I'm really pleased to say that after our CDC funding ended in summer of 2019, CalOptima actually stepped in and is continuing to fund this project so that nursing homes can supply themselves with the chlorhexidine soap and the nasal iodine product so that they could continue implementing this protocol and see hopefully continued reductions in infections. So there were 16 nursing homes that were part of our SHIELD collaborative, and now we're up to 24 nursing homes that have just adopted this as part of their standard of care. And we continue to go out and support with training. So, and all of our toolkit materials are available on our website, which I linked here, ucihealth.org/shield. So just to encourage anyone, in any county can download the materials and see the training that we had developed for this. And because of the work we had done with the SHIELD Orange County project, we had developed a really close relationship with many of the nursing homes here in the county. And so about a year ago, or early last spring, over a year ago now, when COVID emerged as this really urgent threat to public health, and especially to nursing homes, we received 2 phone calls almost back to back. One was from Orange County Department of Public Health, and the other was from our partners at CalOptima, the Medicaid group here. And they both approached our group with the same idea. They said, you have this partnership with nursing homes. You've been doing all this great work with the SHIELD project. How can we all work together to do something to support these nursing homes when it comes to COVID? So that's how we quickly gathered together and launched as the Orange County Nursing Home Infection Prevention Team. And we launched a campaign called Stop COVID. And again, we developed a whole toolkit to provide education and training to the Orange County nursing homes to prepare them as best as possible for safety during this pandemic. So the next few slides in my presentation, I'll tell you a little bit more about the work we've been doing. So this was, our team is led by Dr. Susan Huang, who I should mention is the Medical Director for Infection Prevention and Epidemiology here at University of California, Irvine. So she's an infectious diseases doctor and has expertise in the field of infection prevention. So she spearheaded this project, and we have a large team of coordinators who helped to support it. And this was, again, a collaboration. Just like SHIELD, we had support here at local public health. We were supported by our county's Department of Public Health and the local Medicaid agency, which provide a lot of the payment for nursing home care. And together, our goal was, 1, to provide information and to support that with training and guidance when it comes to infection prevention. And really, guidance is one thing, but we really wanted to help make sure that it was being implemented in a high fidelity way. So we could have the best textbook written, but really making sure that nursing homes have the tools to do it well. We also supported with some of the logistics when it came to COVID testing, and more recently with vaccines as those became available for long-term care in December. So I'm going to highlight a few things from this project. So there's a number of infection prevention activities that we're all familiar with now over the last year: masking, hand hygiene, staying distanced, screening, all of these different things. And I like to show this picture because we think it's important to layer up as many prevention strategies as possible, because anyone can have a loophole or a failure. It's not always done 100% correctly. So because of that, you need to have as many tools in your arsenal to promote safety and ultimately to prevent the spread of this really contagious virus. 2 things I'll highlight here, just because we found it interesting as we were working really closely with nursing homes. A lot of attention was focused on the break room, and we were really concerned about this area because that's where staff take off their mask to eat or take a break or drink some water. And a lot of the nursing home break rooms were really small. It was very hard to encourage social distancing. So we worked really closely with the administrators at these facilities to set up safe break room areas and give reminders about how you can safely remove your mask and how to do that in the best way. The other area that was challenging is really encouraging people to speak up when they had any kind of symptom and to stay home when they're not feeling well. And I wish I had a slide with these data, but there's been surveys in healthcare that doctors and nurses are among some of the worst when it comes to working while ill. They'll take a Tylenol, they want to tough it out, they have an obligation to their patients, and it comes from a good place oftentimes, but when it comes to a pandemic disease, staying home, even with the slightest sniffle, when we might normally say, I feel fine enough to work, was really important and really challenging. And one more thing I'll mention here, and it's a major difference between the nursing home workforce and the hospital workforce, is I strongly think that the nursing home workforce is underpaid. A lot of the staff members we've been working with, I would say, are economically disadvantaged. So and I know there was different policies in COVID for sick pay and things like that, but fear of lost wages is a really big concern. And we found that some people were nervous to speak up because they were afraid that if they had to stay home for 2 weeks, that they wouldn't be able to pay their bills. And I think this whole pandemic has really opened everyone's eyes to a lot of the disparity that exists. But this strategy of staying home when ill, it took a lot more careful communication to really understand the barriers to this. So it's something we worked really closely with managers to give praise when people would speak up, even if they had a slight sniffle. So I just thought that was worth mentioning here because it's something that wound up taking a considerable amount of our time to promote safety during the last year. All of our toolkit materials are available on our website here, ucihealth.org/stopcovid. We had detailed protocols. We made kind of easy, colorful posters because we know people are busy. They don't have time to always read our 10-page protocol. We made frequently asked questions and a few videos to really walk through. So everyone attunes to different learning strategies. So we tried to get as many different kinds as possible out there quickly. And we updated this over the last year. Just some highlights. We had detailed videos on how to put on personal protective equipment, so gowns and gloves and masks, and which mask to wear when. So we really wanted to make it easily digestible for these nursing homes who were under a lot of stress. So we tried to give them as many tools as we could. We showed people what 6 feet of distance looks like. And actually, when we would go into these buildings, we would bring our measuring tape and just show people a visual reminder. It's oftentimes longer than you would think. So we as many different tools. Here's a picture of a training session we were doing where everyone got a mask and also a bottle of hand sanitizer. And we taught people how to properly wear your mask and how to clean your hands and tried to get people as distanced as possible. So we did this at a number of nursing homes. We'd actually go out and do training. And again, we had all these different kinds of visual reminders. So one of the big ones is making sure your mask is covering the nose and mouth. This was something we saw time and time again. You know, people get mask fatigue. They're wearing it all day, especially inside of these skilled nursing facilities. We'd oftentimes see the nose peek out or people pull it down under their chin. So especially in the nursing home where the population is just so vulnerable to the spread of disease, keeping that mask on properly was something that we worked really hard to encourage. Also that sometimes, you know, if you're wearing a mask all day, it could get sweaty, it could slide down off of your face. It's okay to pick it up and, you know, scooch it back so it's over your nose. But we reminded people that if you're going to touch your mask, think of it as an extension of your face and really make sure you clean your hands before and after, especially if you think of this in the context of somebody who's caring for a resident who could have all sorts of medical vulnerabilities. Another thing, and this was especially important in the break room, is at first we were seeing people would take off their mask to eat and just throw it on the table. And we know from other work we've done with nursing homes that cleaning is not always done in a high fidelity way. So we always encouraged people, where's my mask bag? Keep, like I have this brown paper bag that I keep my mask in when I'm not using it, or you could use just a regular Ziploc kind of bag. But we encourage people to have a safe storage space to hold their mask when they're not wearing it on their face. We also spent a lot of attention on hand hygiene. So how to properly clean your hands. And I know many of you work in healthcare. This is something that's been studied for decades. How do we get doctors, nurses, anybody to clean their hands often and to clean their hands well? And it's just one of those challenging human behaviors, because everyone thinks they know the right way, but actually I want to take a moment to show you how we train at our nursing homes. So I'm going to take my hand hygiene here, and we like to remind people about the different surfaces of the hands that are important to clean. So for example, I just put a pump of hand hygiene on my, of hand sanitizer on my hands, and I'm going to clean the fronts. So let me get up here, fronts, the backs of my hands, in between my fingers, the thumb, which is kind of its own thing. You don't normally get it if you're just going around. So thumb, wrist, and that's especially important for healthcare workers who are taking on and off gloves, and then the fingertips and really the fingernails. So rubbing it in. And when I clean all of those 6 surfaces, the hand gel is completely rubbed into my hands, and it takes about 20 seconds to really do it well. So we like to just give people reminders. If they count the 6 surfaces, then they're able to guarantee that or have a best chance that their hands are being cleaned well. And we would do some observations, and a lot of times we'd see people take some hand sanitizer, they'd do a quick rub like this, and then they'd go like this because they have so much extra on their hands, they just need to air dry it off. But when you really rub it in on all surfaces, it gets absorbed, and you don't have too much extra on your hands. So, and we also give guidance, you know, when you're washing your hands with soap and water, which is also important, especially when the hands become soiled, to wash for 20 seconds. And I also like to think of these surfaces when I'm washing my hands at the sink, or if people like to sing happy birthday twice, something to get you to about 20 seconds. And in our nursing homes, we would actually introduce some timers to say, okay, we're going to count down from 20. And we would do some fun things to try to encourage the managers to name people as hand hygiene champions if they were really seen doing a good job. So any incentive we could get, we had little pins, different things to just encourage people to make this second nature, especially in the nursing home. Here's some other highlights of different posters that we made. In the break room, we were highlighting, you know, take a seat that's 6 feet away from others, even if it's your friend. You know, I think, and we did a lot of observations in these nursing homes. There's kind of this idea that when they take their mask off, they're in this bubble that the risk of this pandemic doesn't exist anymore in the break room. And I know things are changing a little bit now, but especially a year ago when we were doing this, really to remind people that safety is important, even when they're on their break. Storing their mask in a clean bag and cleaning their hands frequently, reminders about the symptoms and to speak up if you have any of these symptoms, and then other reminders we would just put up in the hallway or near the hand hygiene dispensers about the surfaces of the hands and to keep their mask on. So as many visual reminders and different strategies that we could in our toolkit, we did and made it colorful and eye-catching and all of that stuff. And then in the more recent months, starting in the winter time, we started to help nursing homes with their vaccine campaigns. And at least many nursing homes were offered contracts through CVS and Walgreens for vaccine clinic dates. So we advertised those dates so that the staff knew if you're not scheduled to work on whatever it was, Wednesday, January, something, that's the day you have to come in. That's your opportunity to get your vaccine. We also went out to some of the vaccine clinics and we're seeing some common mistakes. They weren't always cleaning hands between giving injections. So we made reminders and put this out to even the CVS and Walgreens staff that were coming in so that they were staying safe while they were in the facility. And we made some stickers to just kind of encourage people to be excited and about getting their vaccine. So that was more earlier this year, and at the end of last year, we started to push for this. So that's kind of just a story of what we've been doing here in Orange County for the last few years, working together with nursing homes. And my key takeaways from this work are, one, what we've always known is that nursing homes are high-risk settings for infectious disease outbreaks, and the people receiving care in nursing homes are among the most vulnerable in our communities. We've learned that patients are safer when facilities work together to prevent infections. And we've learned that there's a lot of more work to be done. There's training, resources are needed to support infection prevention programs in nursing homes. And that going back to basics is really important. Things like hand hygiene or bathing, cleaning in the environment, working well. And what I mean by that is not coming to work when you're not feeling well, and creating this culture of safety. And to encourage this, it really does require monitoring and feedback from managers, giving praise to those who do it well, and making targeted improvement. So this is what we've learned here in Orange County, and I'm really excited to hear and answer questions. I know there's a lot in the chat I haven't been able to see with my screen being shared, so sorry if I've missed your chat, but would love to thank you all for your time and then totally open the floor for questions.
Great, thanks so much, Gabrielle. This was extremely informative, and I know we talked before, but I feel like I just learned so much through this presentation as well. So thanks again. We had a few questions in the chat, and I had one as well, but I think I'll start with the one that was in the chat. I believe it was from Dorothy. She had a question about, I believe it was the infection prevention protocols, and if it was if it was for everyone who had surgery or who that was targeted for.
Sure, so it's a great question. So that the CLEAR trial that I highlighted, that was for MRSA carriers on discharge. So not the broad surgical population, but it's actually an excellent question because we strongly believe that in addition to pre-operative bathing, post-operative bathing could be a really important part of preventing infections. And actually, Dr. Susan Huang is working with some partners to try to make that our next trial. So you're exactly in line with what evidence needs to be created. So hopefully more work to come on that, specific for the post-surgery population.
Absolutely, great, thank you. Janice, I see you have your hand raised.
Here we go. Can you hear me?
Yes, we can.
Thank you. Thank you. I was very glad to see your reference to culture of safety. And I wonder if you can talk a little bit about how leadership has contributed to developing a culture of safety.
Really good question. And I think this is something we've been learning after our Shield Orange County project. So we had 16 that were part of our initial program, and then Medicaid opened it up. Any nursing home that wanted to could raise their hand and receive funding to actually continue this program. And I think we were a little bit humbled when not everybody raised their hands. And a lot of that, I think, comes from enthusiasm from leadership. And a lot of the nursing homes are owned by larger organizations, so we've been able to build partnerships with them, and the ones that see the value in this type of thing adopt it and advertise it, put it in their brochure, and are proud to be part of this. But unfortunately, we've learned a lot of leadership just saw this as more work, and they feel so overwhelmed that they didn't want to do something, even if we showed that it prevents infections and will prevent transfers to the hospital. So it's something we face as we're trying to get more nursing homes to adopt this and to at least adopt any kind of infection prevention quality improvement initiative. So I agree that support from the highest leadership is really pivotal to making these programs successful. They have to be willing to invest the time and training, and oftentimes it's seen as more of a burden than a help, which is something we've learned over the last few years. And hopefully that will change. Even with incentives, it's been hard to get people to really want to take something on new.
Yeah, we talked about that a little bit in an earlier meeting, and it does seem it becomes ultimately maybe a systems problem because everybody is very busy. You can understand why leadership might respond that way, but right. Everybody is stretched, right? Everybody's very busy and overwhelmed, and so it seems to be even at a more fundamental level, right? In terms of, okay, the system's a little overdone, and how can we redo that? Yeah,
absolutely. So
there's a little job for you.
There's a lot of work to be done, that's for sure.
Yep, always. Great question, Janice. So Gabrielle, I really like the collaborative approach that you've taken with the hospitals and the nursing homes. And one of the questions that we got a lot was, how can family caregivers help keep their loved ones protected from infections as well? And I don't know if you can talk about kind of from outside the nursing home during COVID, kind of what you learned there, and anything else to add.
Yeah, so it's a great question. I would say one thing that just pops to the top of my mind is if you have a loved one who's getting care in a hospital, nursing home, anywhere, you could ask, when we learn this with our bathing, has my loved one gotten their bath today? So just asking. And actually, I wish I had a slide for this, but during SHIELD, we created posters that said, have you had your bath today? And we just put it up, and it had little bubbles on it and something to just, don't be afraid to ask. And we learned that sometimes if it's the end of somebody's shift and they didn't make it all the way down the hallway, that those patients don't get bathed until the next shift. It gets missed. So I would say not being afraid to speak up about even simple things like bathing. And same thing with hand hygiene. If you notice that somebody's not doing hand hygiene and coming into the room, don't be afraid to speak up. That's something we've been trying to encourage between staff in the facilities to, call each other out in a nice way to promote safety. And as patients and loved ones and caregivers, we could also be part of that culture of safety that speak up. It could be really important. I'm trying to think. So I think that's definitely one approach. The other thing too that we've learned, especially with nursing homes, is we would engage with local ombudsman groups and patient advocacy groups. So here in Orange County, we have the Council of Aging, and we would actually go out and speak with them and the resident councils at these facilities and just hear people's thoughts. And especially when we were doing the SHIELD project, we were changing up the soap on people and wanted to make sure people were happy with that. So we'd go out and talk to the resident council and hear their thoughts and kind of open the discussion and engage the residents in these facilities. Many of them have opinions and thoughts and want to be heard. So we were there to listen. We'd also, anytime we started a new project, we'd actually go and introduce ourselves at the bedside. So just, I'd say keeping the conversation open and like listening to feedback was something really important. Yeah, so those are some strategies, but I would definitely say as loved ones, just asking, not being afraid to ask about the simple things that should be done. Was my loved one's room clean today? Things like that.
Absolutely, those are great tips, Gabrielle, and I agree. I appreciate your point about kind of the culture of safety too, because that takes a culture shift to be able to open the door and make it okay for people to speak up, especially staff within, and to kind of prepare them to also have the family members as a part of that culture of safety as well. So I really appreciate that. It looks like there's another chat from Dorothy. I'm just reading it. Are there ways to get leadership to be a part of this, with such as reduction in Medicare payments?
Yeah. So I know the Medicaid program is local here to Orange County, where they offered it to the 67 facilities here. SHIELD ended in 2019, and at first they were going to say, we're going to evaluate this after 1 year and then put it into permanent practice. But of course, 1 year after that was the middle of the pandemic. So they extended it to a 3-year evaluation period before it would become just a permanent program here in Orange County. I don't know. I know we've gotten, we've been reached out to from other public health departments, like some in Tennessee and some that have heard about our program at conferences and other places. But I think it is something that's initiated locally. And we've been really fortunate here in Orange County to have kind of this partnership between UC Irvine as an academic center and local public health at the county, and then Medicaid. So I think it's a pretty unique partnership that I think should be emulated in more places.
Absolutely. And thanks for sharing all of your kind of protocols and resources and things like that on your website. We'll make sure to get that out and follow up after. And we did have another question about sharing your slides. Are you open to sharing those out as well?
Oh, absolutely. Yeah, I could send them to you, Lynn, after this. And sure, certainly.
Wonderful. Thanks. Any other questions for Gabrielle? Well, I'm kind of curious, Gabrielle, what's next for you now? What's kind of your next step to really continue to focus on infection prevention and nursing homework? What's next?
Sure. So I've been working with this team here at UC Irvine for 5 years, and during that time, I started as a doctoral student. So I'm working towards my PhD in public health. And part of the work I plan to do with my dissertation is to really look at the nursing home workforce. And I think that there's so many disparities, and that nursing home residents are a vulnerable population, but I would argue that the people responsible for delivering care to these very vulnerable people are vulnerable in and of themselves. So I hope to do some work to address that and to kind of understand what support is needed for the employees of nursing homes. So that's one goal. And ultimately, yeah, my goal is to become a professor of public health and lead more studies like this, more quality improvement. I think COVID has kind of derailed us over the last year, but I think the problem of antibiotic resistance is still a really scary threat. And I think in the coming years, I want to return a little bit more to that. And as Dorothy was mentioning too, understanding post-surgery, when are the other vulnerable moments in healthcare that need more attention, and coming up with kind of focused projects to hone in on that. So I think there's a lot of work to be done in infection prevention. I think it'll keep us busy for the years to come. And I'm really excited too to continue to engage with groups like this, patient, family advocates, safety advocates, all of that. I think better together, we are stronger and better together, and we need a lot of collaboration to get these tricky problems solved.
Absolutely. Well, we'll really look forward to more to come from you in the coming years. There's plenty more to learn as well, and we're definitely happy to be a resource to you. Please connect with the PFA network and patients and families whenever you can and have that opportunity. Janice, did you have another question?
Well, just a thought kind of, it's so interesting to hear you talk about the patients and the staff both be vulnerable. And that is such an accepted notion, it seems to me, in our society, right? Like we all know that, and we just kind of accept it. So it's very interesting, and it's a big leap to take to try and make people more aware and not accept that anymore. That needs to change.
Absolutely. I think this past year has really been the straw that breaks the camel's back, and hopefully will lead to more resources being put towards addressing these really big problems.
Absolutely. Great. Any final questions for Gabrielle?
Just a big thank you.
All right. Yes. Thank you so much, Gabrielle. This was really insightful, and congratulations on your impactful work. We're, like I said, look forward to more from you in the future. And thanks for everyone who joined us today. I will go ahead and give everyone 10 extra minutes back to their Fridays, so enjoy them. And thanks again, Gabrielle. We'll get some follow-up out with the slide deck and the links to all of those really great resources. So again, thanks everyone, and I hope you enjoy the rest of your day.
Thank you so much.
Thank you.
Thank you, Lindsay.
Thanks. Bye, everybody.